Madera. We are down kind of by the DMV in the Marin Water District down there, so relatively close. I am a physical therapist with a doctorate in physical therapy, and I'm also a certified strength and conditioning specialist, and that's what the little alphabet soup after my name is there. Am I in your way right here? No? Okay, so I'll make sure you can see. So obviously working at the knee joint, we do mostly knees as our physical therapy. We also do hips and ankles because it's all part of what we call the kinetic chain, and when your foot hits the ground, it goes through your foot, your ankle, your hip, your knee, and so it's all relative and connected and works together. But one of the biggest things when you look at trends in healthcare, most people at some point in time have suffered a bout of knee pain, so that's why we created the knee joint, because there's lots of people with knee problems. Especially I think here in this active community. Like, I don't know one person in this community that doesn't hike, golf, play tennis, run. Like, it's such a very healthy, active community. And so people often have knee pain because they're overactive and maybe not doing everything they need to be doing. So, there's our logo. If you've seen it around, we've done a few things in combination, so you may have seen our logo. It's a knee. I am the lead physical therapist, but I have a physical therapy assistant who's also a certified personal trainer and a CrossFit level 1 coach is what all her alphabet soup is, Rebecca. And we work as a team, so I always evaluate you, reevaluate you, and make sure we do what we call your last kind of checkout discharge appointment, but she kind of helps backfill in between. So we work as a team to get people in, and it works really well. And we both have kind of a different eye for different things, and people love having, like, oh, she picked on this and you picked on that, and it's kind of nice to have both of you guys. And I'm sure you guys have witnessed that with different trainers here, right? So that picks on different forms and has different pet peeves, and it's kind of great. So the knee. The knee is a hinge, so I brought a knee to demonstrate that, right? So just like a door hinge, right, the knee is a hinge. So you would think it's a very simple joint, very easy to deal with. And it's made up of the femur, which is the long thigh bone, and your tibia, which is your long shin bone, and that is the main portion of the knee. But then we also have this joint, which is your kneecap on your femur or thigh bone. So that's kind of the main issues with the knee, what the structures of the knee. But because the knee is not very deep, so you can kind of see it's like a golf tee, right? Not very deep. It does have accessory motions which allow it to pivot and twist and tilt side to side, right? Knees not really like to do that because it is a hinge, right? So this is what we'll kind of talk about here. I'll kind of cut things off a tiny bit. But the front side of the thigh is your quadriceps, quads being 4, ceps being heads. So there's 4 heads to the quads, okay? It has names for each of the individual muscle, but for this sake, we'll just say your quads, right? The bulk of the muscle on the front of your thigh. The back side of your thigh is your hamstrings. There are 3 muscles to the hamstrings, which are listed here. I have a pointer, I can do this. Nice. Yeah. And then the back side of your knee as well, we have from the thigh, there's some support, but below we have your gastrocnemius, which is part of your calf, and it comes up from behind your knee and crosses above, okay? So the knee, though it's not very stable, has a lot of external support to make it more stable. So when someone has knee issues and their knee feels not confident going downstairs or walking across grass and it's uneven ground, how can we help someone? Well, let's beef these guys up, right? So we can make your knee more stable. So people come in and they go, the front of my knee hurts, the side of my knee hurts, the inside of my knee hurts, back of my knee hurts. What are some common things that we see? So I found this great slide that I stole from someone else, but it basically kind of sums up areas to what would be going on. So when I have pain on the outside of my knee, things that are commonly there are your lateral collateral ligament, your cartilage on the outside, so your knee has the outside compartment and inside compartment, okay? So this compartment between these two bones might have less joint height or some cartilage damage or arthritis, okay? The other thing is we have IT band over there, and people hear IT band syndrome a lot, especially if you're runners and tennis players and things. And IT band stems from a little muscle that's way up here at your hip and comes all the way down and crosses below the knee, okay? So IT band syndrome can show up as hip pain or as knee pain, and it can be either one, okay? But that tends to be all on the outside of the knee. On the inside of the knee, which is getting cut off by the handler, sorry, we have the medial collateral ligament, or the MCL, which you may have heard with sports injuries. They talk about it on ESPN and stuff sometimes. Again, the cartilage surfaces being an issue. And also one that's not listed on here, but is very common, is bursitis on the inside of the knee. Okay, so Pezan-Serine bursitis is one that often is a cause with the knee. And also, obviously, meniscus injuries, you can have lateral meniscus and medial meniscus injuries, so both on the inside and the outside. In terms of the front of the knee, or kneecap pain, right, there's a couple of things that can happen. So we can have a mistracking problem. So my kneecap could be kind of crooked like this because of muscle imbalances or a ligament tear or something like that. So that malalignment can cause friction and rubbing of the cartilage in spots that we don't like it to be rubbing on, because there's parts that are a little thicker and more robust than others. So you can have pain between the kneecap and the femur, the thigh bone. And so that is often known as runner's knee, patellofemoral pain syndrome, chondromalacia patella. These are words you may have heard. It's being scared when the doctor hands you a piece of paper and it says that, and you're like, ooh, right? Then you can get tendon issues where my kneecap hooks to my shin bone, the patellar tendon. We can get inflammation in the tendon, so you may have heard patellar tendonitis. That's also known as jumper's knee, so often caused from jumping and landing, right? And then the other thing that's in the front, that's again not listed there, is fat pad irritation. So we have a fat pad here on the front of the knee, which allows us to kneel and not have too much pain. If you ever knew anyone who was like a tile layer or a carpet layer before people wore knee pads, and when you look at their knees, it's like there's a lot of what we call hypertrophy of the fat pad that gets bigger because they're crawling around on their knees. Their body adapts and builds a bigger cushion. Their knees look really funky. Thank God for knee pads nowadays. So that can be what's on the front of the knee. Then when we look at the back of the knee, right? Back here is a lot of open space, so swelling hides back here a lot. So if you're ever like, my knee feels stiff and swollen, but you look at it, well, it doesn't look that bad, reach around and feel back here, because a lot of times it's hiding back there. Then sometimes what we got going on is people, the back of my knee hurts, and sometimes it's hard to figure out exactly why, because like I said, your calf muscle crosses up from below and goes above. Your hamstring muscle comes from above and crosses below. So when I push, say right here, which one is it? I don't really know, right? I can't tell which layer it is. But we know that there's something going on in the back side of the knee, which could be hamstring or calf irritation going on in the tendon and tendonitis potentially. The other thing that hides in the back of the knee is called a Baker's cyst. Now that's something that your body often creates when you have some sort of meniscus tear, interarticular in your cartilage and in your knee, an injury there. So you tend to have, after a tear, you're kind of like a disc bulge in your back, right? People have heard that displaced disc or herniated or bulging disc. Your meniscus can kind of do that if it starts to tear. And it'll bulge a little bit outside of the joint line. And then our body creates a little fluid-filled pouch to make cushion so that that doesn't friction on things. So people who have a Baker's cyst at times may not notice it because it's the size of a pea. Then they may go on a really hard hike or decide to go, oh, let's play 3 hours of tennis. I haven't played tennis in 5 years. Sounds like a great idea. And it'll blow up and be the size of a walnut, right? When it's the size of the walnut, you notice it's there. When it's the size of a pea, you may not notice it being there, right? So that's something that is hiding at the back of it, right? And now when we talk about the knee joint itself, right, we talk about arthritis all the time. And arthritis is being diagnosed as early as like 35. Age-related degeneration. We love to hear that, right? Basically, you're getting old, deal with it. But also deep within the knee is the ACL and the PCL. So they run literally inside, and that helps give the knee some stability. So a lot of times with sports, skiing, you hear ACL, PCL injuries. ACL way more common than PCL, but you can't have both. Any questions on particular aches and pains and locations? We can talk at the end too if you have questions, but nothing right now. Okay. So, I like to educate people on this because how concerned should I be about my pain? Okay? Couple types of pain. Acute, meaning like went to bed, I was fine, woke up in the morning, holy cow, don't know what I did, right? Acute pain. Tends to last 0 to 3 days, sometimes a little more, right? But that is something that, be alarmed, but put on the brakes, rest, ice, elevate, we'll talk about that too. See if it goes away. Subacute pain is things that linger on a little longer, okay? That's something that, as long as you feel like it's a little bit better every day, improving, again, continue trying to treat that on your own. If something's lasting longer than 3 weeks and you've attempted to make it better, you've changed your activities, you've modified stuff, potentially seek some help. Now, in the state of California, you can self-refer to physical therapy. You do not need to go to the doctor, spend a copay, do a physical, all these things, and have them write a piece of paper that says right knee pain. You told the doctor you had right knee pain. You do not need to tell the doctor to tell them you have right knee pain and get a little piece of paper. So you can come directly to physical therapy for 12 visits or 45 days, whatever comes first. Now, if something's really funky, I do refer people out to their doctors, right? But if not, let's try to treat it, and your insurance will still pay for it as long as you are coming into a physical therapy office. So if you're having chronic pain, look for help, okay? Try to address it. Now, common treatments for the acute pain, like I was saying, we use the abbreviation RICE, okay? So rest. Rest does not mean sit on the couch and do nothing. If me normally is come to Fit Club 3 times a week, me coming to Fit Club 2 times a week or 1 time a week is rest, right? It's less than what I normally do. If I normally go for a 5-mile walk, going down to 2 miles is rest for me, right? I think too often people take this as sweet, sit on the couch and eat bonbons. No, keep moving, right? Ice is super important. It's an anti-inflammatory, right? It's relatively free. You probably have an ice pack in your freezer, right? That's something that's important. Compression is another thing you can do. So an ACE wrap, a knee sleeve, nothing super aggressive, right? If you have compression stockings, you are on the airplane, if the swelling is, below your knee, you can wear something like that. And then elevation. Now, elevation is often misunderstood. So people think if I sit in the chair and put my foot on the coffee table, my knee is elevated. Not correct. It's better than being down, but this isn't elevated. We need to lie down and have the knee actually higher than the heart, which means flat on your back, on the bed, on the couch, on the floor, and probably 3 or 4 pillows underneath your knee. So it's elevated, okay? And then gentle movement. Sitting on the couch is not good. I mean, you look 30 years ago, you hurt your back, they put you in the hospital in bed and traction. Now, It's like, get up, go for a walk, go to physical therapy, move. Laying down is not good. Same with the knee. Our body gets stiff, right? We need to move, gentle movement. Doesn't mean go run a marathon, but get out, walk 2 houses down and come back, lay down, ice, elevate. Don't be on the couch too long or sitting too long. Gotta keep things lubed up. Motion is lotion, you know? Gotta keep that going. All right, so common treatments, if the rice doesn't work for a few days and it's lingering a little longer, what can I do? So conservative treatments, physical therapy, right? Sign up for some help, okay? Activity modification, like I said, if I was doing 5 times a week, go down to 3 times a week with exercise, things like that. Then there's a lot of anti-inflammatory measures we have access to. So there's so many different topicals out there. There's arnica gel. There's CBD oils with THC, without THC. There's Tiger Balm. I mean, you name it. I don't know if there's tons of proof out there that any of that stuff actually works, but if it works for you, it works, right? So plenty of topicals. Then we got the non-steroidal anti-inflammatories. I think the 2 most popular ones, Advil and Aleve, right? Pretty much everyone knows those. Ibuprofen and naproxen. Then there's injections, right? Which that does not look super comfortable, right? We don't want to do that if we don't have to. So there are called Synvisc injections, and those are lubricating injections. So if you're getting to the point where you're bone on bone, which I hate that term, but people say that all the time, there is this form of acid, which I'm sure some of you, I'm sorry man, what's this gentleman here, we don't know, but women face cream, a lot of face creams now have hyaluronic acid in it, right? It's supposed to plump, right? It's pumping our face up. Well, you can plump your knee up with the same stuff, hyaluronic acid. But in my opinion, shooting acid into your joint does not seem like the bestest idea in the world. But, hey, can it save you from a knee replacement? Might be worth it, right? The other thing is cortisone injections, right? People get those like candy, especially here in Marin, because I don't know one patient who doesn't have a friend who's a doctor, right? Well, my buddy is a doctor, I can just go get a cortisone shot tomorrow. You can, but the problem with that is too much cortisone can be chondrotoxic. It actually can start disintegrating your cartilage. So if you're already on the lower side of cartilage because you've been told you have grade 2, grade 3, grade 4 osteoarthritis, getting a cortisone injection every 3 months, which I have patients that got it scheduled on the calendar, right? The downfall of that is it does start to break down your cartilage. It can also weaken your ligaments. It can weaken your tendons, right? So we don't want to go that route unless we have to. Now, to me, I've had 1 cortisone injection in my entire life. I was a Division I athlete. I still play water polo now. After this, I'm actually headed out to go play water polo in the East Bay. I've had 1 cortisone injection in my life, and I needed it. I hurt my shoulder. I literally could not pick up my purse, put it on my seat in my car. I could not reach out far enough to hit the start button on my car. I didn't even have to turn a key. Couldn't even push the button, right? I tried to fix myself. I rested. I basically walked around with my arm in a sling for a couple days. I couldn't sleep on that side. I had to, put my hand on the counter and walk back just to put my deodorant on. It was bad. So I asked a friend, who's a doctor, to get me a cortisone shot, right? But it allowed me to get over the hump of my pain, and it allowed me to do the rehab I needed to do to make my shoulder better. So my clients that come in, and they have had pain for 2 weeks, 3 weeks, it's really not getting better. They can't tolerate anything. They're walking, they're dragging their leg, right, moving abnormally. I get nervous, and so I say, hey, we gotta start moving. Are you willing to try a cortisone shot, right? Sometimes people are like, I am not doing anything invasive. I don't want a needle in me. I don't want any extra stuff in me. They do alternative routes, anti-inflammatory stuff like turmeric and, herbal supplements. They may see an acupuncturist. They may see a chiropractor, different things like that. And that's all fine. You do what you do. But if you want that kind of instant relief so you can do the work. Now, some people get that shot and disappear and don't come do the PT because they're like, healed. Yes. No, it was a Band-Aid. The problem is still there. You just feel fantastic right now, right? So I encourage them to go get it, but come back. Let's take advantage of the fact that you're not in pain and your inflammation's down so we can get the work done right now, right? That's huge. And so there are places and time for it. I don't believe in the go every 3 months, every 6 months, and have it a scheduled appointment. That to me is not a great idea, okay? Then, if that stuff's not working, the non-conservative treatments become surgery, right? So now, we got all this nasty looking degenerative cartilage. That's what arthritis looks like on the inside, really yummy. They can replace it with shiny new parts, plastic and metal. Sounds great, right? Shiny all new. Now, what they're also doing is they're doing a partial knee replacement. So if only one side of your knee is worn out, which with women tends to happen because we tend to get knock-kneed, right? So one side of my knee might be totally healthy, and the other side looks really degenerative. So I can have just one side done. They're also doing just a kneecap replacement. So if you've been one of those people that has suffered from patellofemoral pain syndrome for 20, 30 years, and you've worn out the cartilage just behind your kneecap, they can replace just that part too, which can speed up recovery a little bit and also allow you to then have a total knee replacement 10, 20 years later when you need that too. Because if you have a total done when you're 45, you probably need another total done at 65. And to me, I have the conversation with my patients all the time of what's the longevity of your family. My grandmother's 92. So would I have a knee replacement at 45? No, because I'll probably need 2 more in my lifetime, right? Assuming that I'll probably live even longer than that because I'm hoping medicine keeps getting better, right? You don't know. So if people pass away in your family around 70, good, get it done at 45. You might roll the dice and be okay. But if you have good longevity, I say hold out, right? But then there's the quality of life question, right? So it's like I canceled my trip to Europe because I can't walk on cobblestone 7 miles a day, which is what I need to do to keep up with my friends. So you got to make that decision. I love being part of people's team for that. I think having a really good primary care doctor, physical therapist, and orthopedic surgeon on your side, if you're one of these people that you're kind of going that way, is important because it's not a rash decision. There's no such thing as an emergency knee replacement, right? It's an elective surgery you decide to have. Then there's clean outs, right, or arthroscopic surgeries. You hear people getting these done all the time too. I tore my meniscus, I went in, they just cleaned it out. Well, they clean it out, you don't have it anymore. So, in my opinion, torn cartilage or torn cushion in my knee is better than no cushion, right? Now, if a tear's location and size is big enough that it's causing mechanical knee symptoms, meaning my knee locks at times, meaning my knee buckles at times, and I have a huge, loud, audible pop or crack every time I bend and straighten my knee, then we think surgery. Because if I was walking down this flight of stairs and my knee locked, boom, face plant down the stairs, now I'm concussion, broken shoulder, and probably should have had my little knee cleaned out, right? So if you have mechanical symptoms, potentially surgery. If you're having knee surgery for knee pain, bad idea, right? It's probably not going to help, and if anything, it accelerates your arthritis. If I went in and they take out 1/3 of my meniscus, I have 1/3 less cushion in my knee for the rest of my life. It does not grow back. So keep that in mind if you're thinking, oh, well, the doctor said they can just clean it out and I'll be good as new. Good is worse than you woke up, worse than you went into the surgery, right? But mechanical symptoms, please address them because they can lead to other injuries, okay? Any questions on?
Well, I had something about 15 years ago that was, or 20 years ago that was new at the time, and I never hear about it anymore, so I don't know if it's around, but it was called microfracture.
People are still doing that. So that was the idea that your cartilage had damage or had died in a spot, right? So what they go in is they do lots of micro fractures. They drill holes in your bone with hopes to restart the healing process, cause bleeding in the joint. You want that, right? Pretty invasive procedure. Did not feel good for quite a while, right?
Right.
Very painful, non-weight bearing for a while. It's a struggle, right? It can work. It doesn't always work. Now, sometimes what they're doing is they'll take you into surgery. They'll cut a portion of your bone out, put it in a petri dish, grow it for about 8 weeks, and then implant it back into you. And they'll actually do a chondral transplant. Now, they're doing too. Very long, again, recovery, at least a year, I would say, but it can be done. The other thing is there's regenerative medicine out there, so a lot of people in Marin are doing that, and you can do stem cell or platelet-rich plasma injections, and they're supposed to be very similar in treatment, but it only lays you up like 3 weeks instead of 6, 9, 12 months, even though the doctors tell you you'll be fine in 3 weeks. Right? You gotta be careful with that. So there are alternatives. Now, insurance doesn't pay for the regenerative medicine, unfortunately, and it can rack you up 10 grand, but people take advantage of that in this community because people have the money for that.
What about the stem cell?
Yeah, so stem
Is that
cells.
the same thing as a regenerative?
Yes,
medicine?
that's one of the things. So there's platelet-rich plasma, which is a portion of your blood. So that is a little more cost-effective to do and a little less invasive. They draw your blood, they spin it in a centrifuge, and your blood separates. Just like when you go get your blood test and they test your cholesterol and all that stuff. There's a portion of the blood that's rich in these platelet-rich, it's plasma. And they'll take it and soak it into an injection, and then usually under a guided ultrasound, they're finding the damaged area of your cartilage, and they poke you with the needle and insert these cells. The idea is that these cells are kind of ambiguous cells and can become whatever they're next to, right? Stem cells can come either from your bone marrow. You hear people having bone marrow transplants that have leukemia, things like that, stem cell, right? Or they can come from your fat cells. So people are like, sweet, free liposuction, and my knee's gonna feel better, right? Fortunately, it's not enough to be cosmetic, right? It's just enough to fill a tube to fix your knee, right? Or your back or whatever you're doing it for. And so they take the stem cells, same concept, put it in an injection, and put it into specific spots within the joint that they see the cartilage damage. Can be done. I tend to think people get it done and they sit on the couch or go right back to their normal routine that caused their knee damage in the first place. Doesn't do really well, gives it a bad rap. I think the people that take the time, come in, do the physical therapy, fix the repetitive stress they were causing on their knee that caused the cartilage damage, and with hopes of regenerating new tissue, does a little bit better. And there's quite a few groups. I think there's 4 that I can think of off the top of my head that are doing it in different capacities in Marin. So it is an option. Any other questions like that? So PRP and stem cells. Oh, there's a spider on the screen. Fun. There it goes. So what do we do at the knee joint? So our slogan is we're the simple solution for knee pain, and problems. So coming in, we believe in the 3 E's. So your first day, you get an hour-long evaluation. I spend an hour with you. Watch you move, test your strength, test your flexibility, start instructing you in things to correct these problems we saw, right? Educate you on why these problems are occurring in you, right? Why are you worn down on one side of your knee and not the other? Why is my kneecap hurt with stairs, right? Pointing out to you, look at the way you move, right? We need to fix that. Look at how tight this muscle is on one side compared to the other side. We need to stretch that. This muscle is a lot weaker on this side because you had a hip replacement and you never did the PT very well for that, or you did it for 8 weeks and then you stopped, right? We see that all the time. And then teach you to exercise. And you guys are here, so yay, you already do that. But do you need to do something specifically for you that's different than a generic exercise class, right? Generic exercise classes are great. They make you move, they make you sweat, you're using big muscle groups, you're doing big movements. But at times, you need to have your one day that you do the knee exercises, right? So 2-3 times a week you're here, 1 or 2 times a week you should be doing your corrective exercises that your body needs to keep going and keep moving, right? So, couple of things that are important with knees. We need to have joint mobility, so the ability for my joints to actually move, right? Stiff hips can lead to bad knees. So sometimes we're looking at your hips, right? Stiff ankles can cause bad knees. So we're looking at your ankles, right? So we have to look at if your joints are moving well. The other thing is, are your muscles flexible? Those are not the same thing. People often interchange those, mobility and flexibility. They're different, okay? So your joints have to be mobile, and that's usually more ligamentous flexibility. It's the gristle around your joints, right? Or sometimes the fact they have really bad arthritis and it's not going to move whether I sit on it or not, right? There's bone spurs in the way. But muscle flexibility, also important. And I know there's a stretching room that 99% of the time when I've come in here is empty. But you have it to utilize. There's straps, there's mats. I think there's even instructions in places on the wall. Utilize it, right? But everyone comes in, gets what he does, thing, and see you later, and we don't stretch, right? Problem, okay? So I just threw a couple things up here. Hamstrings, right? These are kind of addressing all the muscle groups we talked about, right? Hamstring stretch, quad stretch, front of the thigh, hip flexors, right? These get tight, we sit. Right now, you guys, all your hips are short. I go to stand up and it's like, oh, doesn't want to lengthen out. My stride starts getting short. I start doing my old shuffle because I can't take a long stride, right? Not good. Glute flexibility. This is what we see when people start not being able to squat down because their butt gets so tight that I can't stick my bottom out to go down, right? So we gotta have that. Then the figure 4 stretch, which a lot of people need to be able to put their socks and shoes on, right? Especially as I can't bring my leg up here, I need to be able to bring my leg over here, right? So having hip mobility helps so that I don't stress my knee. Now, strength and stability, super, super important, right? You saw the knee, not very stable, right? Golf ball on a golf tee, right? Not very stable. So, how do we make it stronger? All the exercises you guys hate the most here, right? Lunges. How many people love lunges in this room? No hands. Perfect. Side planks. Who loves those? Oh, we have one left. Two takers. All right, good.
Only because I
She made your trainer's sitting right there. Yeah. Squats, right? Clamshells. You guys do those sometimes?
Mm-hmm.
Yeah, right? Hamstrings, deadlifts of sorts, right? Straight-legged Romanian deadlift, single-leg Romanian. Bridges, glute bridges. We love those too, right? I'm pretty sure you guys have all done all these things here, right? Super important, right? We are working on all different muscle groups. Yes, is your core connected to your hip? Is your hip connected to your knee? Is your knee connected to your foot? Yes, super important, right? We gotta do all these things, right? Now, why is strength so important and mobility and flexibility? So I can move and do stuff I need to do in life. People go, I can't do squats. Then when does this happen? I can't go to the toilet. Unless you can figure out a different way. I like to see people get on the toilet if you say you can't squat, right? Step ups. I know you guys do those sometimes. Why do we do those? So you don't look scared going down the stairs. This lady's hanging on for dear life with 2 hands on the handrail. Not good. Right? This lady, I don't know if you guys can see it, but she's looking at a package on her porch. How the hell am I going to pick that up? Right? That's why we make you do deadlifts, and you hate those too, right? But it's function, it's life, right? You've got to be able to do these basic movements. Your trainers aren't out to get you. They're not mean, right? They want to see you succeed in life, right? You've got to be able to move. It's so important, okay? So, when people come in and go, I have bad knees, I can't squat. How do you get out of your car, into your car? How do you get off the couch? How do you get off the toilet? You have to squat. You are a moving human being, right? I don't pick anything up from the floor. If you live alone like I do, what are you going to do? There's something, you got to figure it out. You got to strategize maybe on how am I going to get down here, pick something up, right? What did I have to have there? I had to have ankle flexibility, knee flexibility, hip flexibility and mobility. I had to have the strength to pick up what was down there, right? It's important, okay? I think that's why you guys are all here at Fit Club working out all the time, but also why you're here today, right, is you probably struggle with some of these things, okay? So, that's what I had planned for today. If there are any specific questions about knee problems, or is there any special questions about, I'm one of those idle squat people, how do we squat? Let's go over specific examples, right? I'm not running out of here right now. So, is there any movement we want to go over? Is there any scenario? I have a chair here for squats. I have a step over here for step up. So what do we got here?
Just a question about injections.
Okay.
So if you just have one injection, are you concerned about that and the impact of that on the body?
Not too much. The downfall, so I've heard of people having some spontaneous tendon tears. If you have a lot of damage in there already, because the cortisone can weaken it for a period of time. So somebody who say, most likely rotator cuff in the shoulder, so not so much in the knee, but if your shoulder's really bad and your rotator cuff is hanging on by a thread and you get that shot, and then I go to pick up something and it'll pop because it does make it weaker for a period of time. But typically, one, like I said, to get over the hump so you can get the work done, sometimes it's necessary. Yeah. Yes?
I had an injury during the summer, last summer, my knee.
Okay.
And I've been going to physical therapy and coming here as well. But I also find that I tend to overcompensate.
Mm-hmm.
Other things are hurting,
Right.
you know,
Mm-hmm.
that never hurt before.
Yes.
So how do you, what do you do so that you don't, how can you avoid that?
Yeah, so when you come into physical therapy at our clinic, right, we look at the differences, right? So if there's a muscle group that's way stronger on one side than the other, it's why you rely on the other side more than the other. I also spend a lot of time trying to educate people on the fact that the entire time you were talking to me, you had no weight on your left leg and you've been standing on your right side all day because of an injury, say, that you had, right? So I think making people conscious of the fact that you're not 50-50 very, very often is something that's huge. So pay attention to yourself doing dishes, standing, talking to someone, waiting in line at the grocery store, waiting in line at the bank, all those things all day long. The other thing is we spend a lot of time working in front of a mirror, and there's mirrors here and mirrors up there, that if you need to, come down and work on your own, because it's amazing. I'm gonna blind myself here. How many people, when I say, show me how you get in and out of the chair, if I have a left knee injury, looks like that. There's a huge shift, and there's like 70% of the load here and 30% of the load here, right? And so if you're doing that all day, good for you if while you were at physical therapy you did a good job 2 times a week for 40 minutes that you're maybe there. But what happened the other, I don't know the math-wise how many other hours there are in the week, right, that you weren't being 50-50, that you weren't utilizing it. The other thing is, you know, if I get to a curb, do I always go up the curb with my right leg? Do I always go down the curb with my left leg, right? Things like that. We have to be very 50-50 and symmetrical or problems persist. Does that kind of help? And I think just like people, and the other thing that I have the biggest pet peeve about is my good knee, my bad knee, my good side, my bad side. It's a right and a left, and they should both feel good. We just gotta work at that, and my right and my left, right? So have faith in your leg. You're doing the right stuff to get there, but now use it. You know, throughout the day, pay attention and see how you do. You know, you're like, dang it, there I go again. I'm standing all on one side and not on the other. Because that's where you might do a great job when you're focusing on your exercises. When I do my 2 sets of 10 squats that my physical therapist prescribed, but then I leave and I go and I sit in my car and I stick this leg out when I go to get in my car and I don't use it at all, right? And so really try to make it so that you're really using your leg all the time, because that's going to help you keep the gains. It's going to help you build your muscle back. Because someone like you, if it's been going on for 6-7 months right now, you may have atrophy in that leg, right? If you look in a mirror, is one leg smaller than the other? Well, yeah, for 6 months I've been doing 70-30. It's going to add up. And then I continue to have knee pain. And then I start having back pain. And then I start having shoulder pain on that side. It just travels up the chain, right? You've got to try to be symmetrical. Nobody's perfect. I know.
I
But-
just wanna add something.
Yeah.
At the knee joint, they have classes, and in the classes, we're always doing both sides, whether we need it or not. We do on the right side, we do it on the left side.
Yeah.
So we're always being symmetrical in our workout in the class and being told.
To do both sides.
Get
Well,
away
they do
with
that
it.
here too.
Yeah, yeah.
And they do it at the physical therapy
Right.
where I go as well. It's just when, real life and you're looking at 16 steps you have to walk up,
Right.
you kind of at halfway through you're like, that hurts. So
Right.
I'm gonna, compensate.
Right. But that's where, if that is your trigger of your pain and your issues, tell your therapist and spend a half a session working on stairs. Right? I don't have stairs in my clinic, but we have stairs in the lobby. So I take you out and we will go up and down until you figure it out. Because do you have knee pain because you're loading it too much, or do you have knee pain because you're scared to load it? Right? That's a question. Do I have knee pain because my alignment's funky on the stairs? Do I allow my knee to cave in when I go down? Again, that knee's a hinge. It does not want the torque on it of allowing my knee to fall in, right? And then if it is the alignment issue and my knee is falling in, why is my knee falling in? Is it because my ankle's stiff and it can't bend forward, so my knee goes in to shock absorb to go around the ability that my ankle won't move? Is it the fact that my quad is not strong enough to hold my body weight to come down to the next step? Right? Is it because my clamshell butt cheek muscles are not strong enough to hold my knee out in good alignment and my knee just falls in? Right? Why? Right? Is the question, and I think that's what we are as physical therapists. We're detectives, right? I love my job because, yes, do I look at knees all day long? And sometimes I'm like, I have that all left knees today. But everyone who comes in is there for a different reason. Everyone has knee pain because of a different reason, right? And to me, it's the detective work to figure it out. I could, yes, give everyone who walked in the door the same cluster of exercises because I assume I see these trends every day in knee pain. But I take the time to do detective work to find out why you particularly are having your problem, and then working on goals like, yes, it's great to get your knee to bend 0 to 130. That's a good goal to have as a physical therapist. But why do you need that, right? I need 0 to 130 because I have to sit on the floor cross-legged because I'm a preschool teacher. Okay, good. There's a reason why you need that, right? So having these goals is super important, and they have to have function tied to it, not just that muscle needs to get stronger, right? That muscle needs to get stronger so you can ascend and descend stairs, right? I think that's what we gotta look at sometimes. And be
You
frank
put out
with
just
your
some
therapist.
business card so we can call you?
Yeah, their flyers are out up there, so all the information is on the flyers back there.
I think I have one
Yes, question here.
So when you're are you diagnosing more than that first 1 hour?
Yeah, I mean, it's constantly evolving, right?
Oh,
So you
it is.
come in and, you typically will come in, I would say, thank you for coming. You typically come in for a bout of physical therapy, right? So I would say most of our clients are coming in for 6 to 8 weeks because it takes that long to change behaviors, right? Were you really great at coming 3 times a week when you first started here? No. 2 years later, you've bought into it, you feel better, you know you need it for your body, right? So you're coming in here and your behaviors have changed, right? Often that leads to you eating better and sleeping better and all these things because you're just doing better. PT is the same way. So you come in, the first day you leave, we may give you 3 things to work on, right? But by the time you leave, you have a 45-minute routine that I expect you to do a couple times a day. Like I said, on the off day that maybe you don't come here, right? So it's constantly kind of building and evolving, and you may come back and say that I did this exercise you gave me for the last 3 days and some things works. Okay, well, let's strengthen that muscle in a different way. There's not one way to work a muscle group, right? So we
But
can
you're
change
watching
that.
our movement and
Oh,
seeing
yeah.
if our
Yeah, you're with
alignment's
us
off.
every other follow-up, you're with us 45 minutes one-on-one. So very different than most physical therapy clinics. So I would say we're kind of on a concierge model to an extent, right? Because I've worked in the high volume, lots of turnover clinics where I saw 20 patients a day, and I still felt I was helping people, but not as much as when I only see like 8 patients a day now, and I spend more time with you. The thing I also believe is that I can now get you better in 6 to 8 sessions instead of 12 to 20 sessions because I spend more time with you each time. All right, so instead of getting 20 minutes with you 12 times, getting 45 minutes with you 6 times, and we get better faster, which is good. But yeah, it's constant about Mary's
The
been.
evaluation's amazing. It's great, because I've had, we've switched insurances since I've seen
Thank you for
Danielle.
coming in.
Thank you very
And
much.
often it's better.
Her evaluation was amazing. The second person I went to was just like, okay, blah, 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 do these exercises. It was nowhere near as thorough as Danielle is.
Question.
You ever need to have people get x-rays or so you can see what's going on?
So, I like to quote this doctor that I worked with in the past, and there's a bad word in it, but I'm going to use this quote anyway. So, I had a patient when I first started out. I suspected this patient had a pretty significant meniscus tear. So I said, I think you should go back to the doctor. I think you should get an MRI. So then I asked her, when you come in, can you bring your MRI report just so I can see the location of the tear and how big it is and the description of everything that's going on in there. So she goes and she asks her doctor's office. My PT would like a printout of what was in the MRI. And the doctor called my boss at the time. I was fresh out of school, scared little physical therapist, and said, you tell your physical therapist to do her shit and I'll do mine. So the doctor seems to think, and most doctors seem to think, that I don't need to know what's going on inside your body because I can't fix that anyways. I can't go in there and clean your meniscus tear. I can't go in there and change your arthritis, okay? And I agree with that to an extent, right? So since then, I've honestly tried to operate not looking at any of that stuff, right? Now, if you came in and you had all those mechanical knee symptoms, and I was able to make your knee lock, and then you're like, oh, see, this is what happens, and then it takes like 5 minutes so I can bend my knee again, I would encourage you to follow up with an orthopedic doctor and get the MRI and look at stuff, right? In terms of arthritis, if you're bone on bone, there's nothing I'm going to do about it, and there's nothing the doctor's going to do about it unless you decide to sign up for that knee replacement, right? Again, it can give you a cortisone shot, makes you feel better. Does it fix the problem? No. What's going to fix it is getting more strength and support around your knee to take pressure off of that bone-on-bone situation. Does that make sense? Okay. Any other questions?
Thanks so much.
All right, thanks for coming. Cool.